Okay. Assalamu alaikum and good afternoon. It's a great honor and privilege to welcome you all in another session of National Heart Foundation Cardiac Course. Today our guest panelist is one of the renowned cardiologists of Bangladesh, Professor Dr. A.K.M. Fazlur Rahman. He is now the Professor of Cardiology, Bangabandhu Sheikh Mujib Medical University. And he is currently President of Bangladesh Society of Cardiac Intervention and Vice President of Bangladesh Cardiac Society. He is also author of a couple of books on cardiology. Today, we have a very important topic of discussion, that is infective endocarditis. As you all know, despite significant advances in the diagnosis and treatment of infective endocarditis, the first 6-month mortality still approaches 25%. And in addition, with ever-increasing use of different intracardiac devices, the incidence and prevalence of infective endocarditis has not changed over decades. And there are increasing number of resistant bacteria, which made it more difficult to treat infective endocarditis. So today we'll try to discuss about all these issues. We have got great speakers with us. They will 4 speakers. They will discuss all aspects of infective endocarditis. So with the permission of chair, I want to start. Our first speaker is Dr. Ismat Ara. He'll be talking about etiology, pathogenesis, and definition of infective endocarditis. He is registered of our hospital, and she'll be talking about these topics. Dr. Ismat Ara, please.
Respected moderator, all expert panelists, and learned audience, Assalamu alaikum. I'll be presenting etiology and pathogenesis of infective endocarditis, the most common cardiovascular infection. Infective endocarditis is a disease caused by microbial infection involving the endothelial lining of intracardiac structures such as the heart valve. Infection commonly resides on one or more of the heart valve leaflet, but may involve mural endocardium, oral structures, deeper layer of the myocardium, and the pericardium. Infection is invariably fatal if left untreated. Before the pandemic of HIV infection, infective endocarditis was the syndrome for which expertise of infectious diseases physicians was most initially interested. In 1885, Sir William Osler defined and described this. The United States insists 2 to 4 cases per 1 lakh population per year. It is similar in other countries. The rate has risen significantly from that of the previous 50 years. Male outnumbers female by 3 to 1. It has no racial predilection. More than 50% patients are older than 50 years, but it can occur at any age. The age of the subjects with endocarditis have increased over the past 60 years. Before 1940, mean age of onset was 30 to 40 years, but it has moved up, and at the present era, the mean age of having this infection is 50 to 69 years. Mortality rate is 20 to 30%. Mitral valve most commonly involved. Then, in decreasing order of frequency, aortic valve, combined mitral and aortic valve, tricuspid valve, and the pulmonary valve rarely involved. Mechanical, prosthetic, and bioprosthetic valves exhibit similar rate of infection. A vast array of organisms are responsible for causing different types of infective endocarditis, of which staphylococci is responsible. Staphylococcus infection is usually associated with acute infection, prosthetic valve endocarditis, endocarditis related drug abuse, catheter related, and cardiac device related endocarditis. It has mortality rate of 40 to 50%. 3 imported species, which is the Pogres positive, is largely responsible, and 2 other negative staphylococci are Staphylococcus epidermidis and Pathogenesis. Second largest group of bacteria are Streptococci. Streptococci viridans usually causes native but previously damaged or abnormal endocarditis. Most of the cases they cause subacute infection. Some of them are normal flora of the gastrointestinal or genitourinary tract. Few species pose major resistant problems for antibiotics, such as Group D. Group B infection, Group B bacteria causes infection in pregnant patient and elderly with higher mortality. Enterococcus faecalis, the important pathogen of Enterococci family, are the part of normal flora causing community acquired infection. Elderly people are more vulnerable. Among the gram-negative rods, HSA group of organisms is the most common. They cause subacute disease and community acquired infection. Pseudomonas aeruginosa usually causes acute disease. E. coli, Klebsiella are the uncommon cause of infective endocarditis. Among the fungal family, Candida species is the most important. It causes endocarditis in immunocompromised state. The use of endovascular ICU admitted. Polymicrobial, where more than one infectious agent are involved, are responsible for 7% cases of infective endocarditis. Pseudomonas and Enterococci are the most combinations seen in intravenous drug-related endocarditis. This diagram shows the relative contribution from different etiological agents. It is seen that the largest contribution from 3 gram, namely Staphylococcus, Streptococcus, and Enterococcus. These small gram-negative rods, fungus, culture negative, and other agents. Infective endocarditis can be classified in many ways, depending on the rate of progression of the disease. Weeks, days to it shows toxic presentation, progressive destruction, metastatic infection, most commonly caused by Staphylococcus aureus, Pneumococcus, Streptococcus, and Enterococcus. It can occur in previously normal heart, having much more complication. On the other hand, less invasive and less aggressive subacute form presents over weeks to months. It shows slow indolent clinical course, having non-specific symptoms. It rarely leads to metastatic infection, most commonly caused by Streptococcus viridans or Enterococcus. Depending on the valve type, it can be native valve endocarditis and prosthetic valve endocarditis. Native valve endocarditis is seen in chronic rheumatic heart disease, congenital heart disease, mitral valve prolapse with mitral regurgitation, and degenerative valve disease. It is usually confined to leaflet. Offending organisms are Streptococcus viridans, bovis, and Enterococcus. Staphylococcus is also responsible for 1/4 of cases. It generally shows a more aggressive acute course. Prosthetic valve endocarditis can be early or late. When it occurs within 2 months to 1 year of surgery, this is called early. And when it occurs after 1 year of surgery, this is termed as late. Etiological agent and mortality varies between 2 groups. Staphylococcus aureus, especially methicillin-resistant one, and Staphylococcus epidermidis are the 2 pathogenic agents. Whereas in case of late infection, it is largely caused by Streptococci and Enterococcus, similar etiological agents that are responsible for causing native valve endocarditis. Early group shows higher mortality rate compared to late group. Up to 80% of cases, etiologic agent can be detected through culture media. Up to 20% it remains culture negative, which is defined as endocarditis without positive blood cultures after the inoculation of 3 blood samples. Possible causes may be organism can be highly fastidious, culture technique may be inadequate, there will be a start of antibiotic therapy prior to obtaining blood samples, bacterial, non-bacterial pathogen, or it can be non-infectious endocarditis like Liebman-Sachs, which is found in antiphospholipid antibody syndrome, systemic lupus erythematosus, malignancy, or in the post-cardiac surgical state. According to etiological agent, it is again divided into bacterial, which is the predominant group, and non-bacterial, which is mostly caused by fungi. Fungal infective endocarditis is seen commonly in drug abuse, immunocompromised state, and after cardiac surgery. It is associated with large, bulky, friable vegetation that can obstruct valve orifices and can also embolize to large vessels. It's a frequent indication for surgical replacement of the infected valve carrying highest mortality. Survival rate is less than 20%. Right-sided endocarditis predominantly involve tricuspid valves seen in intravenous drug users having higher cure rate. Mortality rate is low unless there is bilateral involvement. Left-sided endocarditis occurs in aortic and mitral valve. Despite adequate treatment, mortality and morbidity of this endocarditis is very high. According to mode of acquisition, it can be community-acquired or healthcare-associated infective endocarditis that is seen in central or peripheral intravenous catheters, devices like pacemakers and defibrillators, hemodialysis shunts and catheters. These patients tend to have significant comorbidities, more advanced age, and with higher mortality. Intravenous drug abuser-related infective endocarditis. In this variety, tricuspid valve is commonly involved. Patient usually has history of previous hospitalization, long-term addiction, and non-prescribed antibiotic use. Most of them do not have any past history of heart disease or murmur on admission. Staphylococcus aureus is largely responsible. Streptococci and enterococci can also cause this disease. Intravenous drug-related endocarditis can also affect left-sided valve. It results in major complications like systemic embolism. Device-related infective endocarditis. Overall incidence of this category lies between that of native and prosthetic valve endocarditis. Staphylococcal species are the most offending organism. Most of the cases, patient gets this infection during pocket site contamination during device implantation. Septic pulmonary embolism is the frequent complication and contributes to the higher mortality. Percutaneous extraction with device reimplantation to other site is the procedure of choice. Population that are at the highest risk for developing infective endocarditis are patients with prosthetic that can be percutaneously or surgically placed, previous history of infective endocarditis, any type of cyanotic congenital heart disease. Repaired congenital heart disease with a prosthetic material, patients with surgical palliative shunt or conduit, repaired congenital heart disease with residual shunt or valvular regurgitation. Intravenous drug abusers, intravascular indwelling catheters, dental procedures, cardiac surgery, and post-cardiac transplant patients. Pathogenesis of infective endocarditis involves a series of complex host-pathogen interaction. There are three commonly shared processes. The first one is endocardial injury that results in the formation of non-bacterial thrombotic endocarditis that is also known as sterile vegetation. Then adherence of the bacteria which forms the vegetation and eventual invasion of the valvular leaflet and embolization of the vegetation. Endocardial injury usually resulting from valvular or non-valvular cardiac structural abnormality. Usual sites are atrial surface of the incompetent atrioventricular valve and ventricular surface of the incompetent semilunar valve. Intact endocardial lining is disrupted or damaged by turbulence of blood flow. It exposes tissue factor and collagen that attracts circulating platelets. Later, fibrin deposition occurs, and there is formation of non-bacterial thrombotic endocarditis or the sterile thrombus. Later, bacteria invade and attaches to the sterile thrombus. Bacteria in the circulation can come from various sources like skin and wound infection. It may come from trauma to the heavily colonized mucosa following dental extraction, surgery to the periodontal space, or source may be intravascular indwelling catheter, intracardiac devices, or it can be from intravenous drug abuse. The bacteria adheres to the sterile mass and to each other by adhesing molecule form dense microcolonies, releases tissue factor, which attracts more platelet, results in platelet aggregation and other inflammatory cells accumulation. All this combined form mature infected vegetation. And this is the pathological hallmark of infective endocarditis. So a mature vegetation usually contains platelet, fibrin deposition, enmeshed organism, and moderate inflammatory cells. After formation, this vegetation can locally damage valves or it can break off from the site of formation, circulates in the blood to embolize in different organs of the body. Here, vegetation is seen on the atrial surface of the mitral valve leaflet and ventricular surface of the semilunar valve or aortic valve leaflet, a large vegetation over anterior mitral leaflet. There is another vegetation over posterior mitral leaflet, vegetation seen on native and prosthetic aortic valves. Patient of infective endocarditis usually presents with diverse clinical manifestation, and all this manifestation comes from effects of vegetation that can be local or metastatic, and or it from host response related complications. Vegetation can locally impair valvular coaptation, or it can perforate a chordal rupture, leading to worsening of the regurgitation and congestive heart failure by extending to the surrounding structures. Myocardial risk can result in conduction defect, abscess, diverticula, aneurysm, or fistula formation. In case of prosthetic valve, it can invade paravalvular tissue, resulting in abscess formation and valve dehiscence. Embolization, vegetation can embolize to spleen, liver, brain, kidney from left side, and from right side, it can go to pulmonary vasculature, causing pulmonary embolism. Effects from host immune response is mainly responsible for extracardiac manifestation of infective endocarditis that result from the circulating immune complex formation. This immune complex is deposited at different parts of the body and can result in glomerulonephritis, peripheral manifestations like Pathogenesis, Osler's node, Roth spot, Splinter hemorrhages, and Janeway lesion. Janeway lesion usually arises from infected microemboli, not immune complex mediated vasculitis. Thank you.
Thank you, Dr. Ismatara, for your detailed lecture and on the topic of pathogenesis and classification. We have got one question for you. The question is, why pulmonary valve is less involved? Is there any reason why pulmonary valve is less involved? Can you?
Sir.
Ashok, anybody else want to answer? Why pulmonary valve is less involved? Dr. Wadud, do you have any thought?
The right side of the heart are subjected to lower pressure changes that lead to lesser chance of any injury to those valves. That's the answer.
Exactly. Thank you. Thank you, Doctor. And another question, similar question, why infective endocarditis is common in mitral valve? As we know that is most commonly occurs in mitral valve. Is there any special reason why it is so common?
Mitral valve is actually between a high pressure zone because it is part of the LV outflow tract. Also a low pressure zone is subjected to two types of shear stress. Probably that is the reason. And it's a very complex structure.
Actually, it is the statistical findings. If you look for the rheumatic heart disease involvement of the valve, the infective endocarditis follow the same sequence. First the mitral, aortic, then tricuspid, then pulmonary. Why is the reason? It is not exactly explained, but it's a statistical graph. Another way it may be that actually nidus of the vegetation is at the upstream part of any regurgitant flow. The more the differential pressure between the upstream and lower stream, the more the chance of injury. You can see the for mitral valve, whenever there is mitral regurgitation, it is the mitral valve on LA side, that is the upstream side for MR. Here is the most common nidus for vegetation. And same also for aortic valve. So these are the sequence. Sequence is like an rheumatic heart disease involved.
Actually, underlying pathophysiology is the low chamber side, low pressure side. আমরা যদি আমি যেটা সচরাচর ছাত্রদের বলে থাকি যেখানে জাহাজ এসে ওই এর সাথে লঙ্গর করে মানে লাগে তার পাশেই কিন্তু ওই পানিগুলা ঘুরপাক খাইতে থাকা ময়লাগুলা কিন্তু ওই লো চেম্বার সাইডে জমা হতে থাকে দ্যাট ইজ ওই জাহাজের যে প্ল্যাটফর্ম থাকে তার পিছনে জাস্ট লাইক দ্যাট whatever may be the underlying lesion the low pressure side is the position for the vegetation. And regarding mitral regurgitation, what Kovirujaman said is 100% right. Actually, why mitral valve vegetation is more common, it is not exactly known. In pulmonary valve, Though it is very rare, but there may be infective endocarditis in the pulmonary valve, but it is lesser with respect to the other valve. Thank you.
Thank you, sir. Thank you for your valuable comments. So our next speaker is Associate Professor Dr. Tawfiq Shahriar Haq. He will be talking about clinical presentation and diagnosis. He is Associate Professor Interventional Cardiologist in our hospital and also has a special interest on structural heart disease, doing a lot of devices. So, and he will be talking about clinical presentation and diagnosis. Dr. Tawfiq Shahriar Haq.
Assalamu alaikum, sir. Is my screen visible?
Yeah, it is visible clearly.
So, thank you, respected moderator. So, infective endocarditis has a high mortality rate. As an opening slide, probably this statement is not very appropriate. But let me just give you an example. I see a 5-year-old girl today who has a perimembranous or muscular VSD 3 millimeter. I tell her, we keep you on follow for next 5 years. After 5 years, when she comes back, I still see that vegetation is there. And I tell her that, okay, your chances of developing infective endocarditis is 0.003% or so. So why take so much of hassle? Just let's keep you on follow. At the age of 17, she comes back to me with fever and diagnosed as infective endocarditis. Now I change my statement and tell her that you have got this severe disease and your 1-year mortality is approaching 40%. So was I being just to her 12 years back? And now let's come to another example. If a patient comes to me today with high-grade fever and tells me, I had a cardiac surgery 2 months back, and he's suffering from high fever, palpitation, shortness of breath, leg edema, and I immediately jump to the conclusion that he has endocarditis and start treatment. But if this patient comes to me after 20 years of surgery with low-grade fever and other constitutional symptoms, looking at his X-ray, I treat him as a case of respiratory tract infection. Then his fever doesn't subside. I look into the urine examination and see some RBC and treat her for urinary tract infection. Then after a few days, I look into Vidal titer and treat him for enteric fever. And then I realize probably he has endocarditis. I have spent 6 months' time. I have used up all the antibiotics, and the patient is in deep trouble. So why is this happening? Because if you look into this chart of symptoms and signs, none of the symptoms or signs are 100% diagnostic of this disease. The patient complains of feverish feeling in 80% of times. And if I, in my chamber, look for core temperature, I would get 95% times I would get high temperature, and all others attribute for 25 to 50%. So what are the other symptoms? Fever is usually universal. It may be absent or minimal in those with severe debility or chronic renal failure. And as Ismat has said, severity may vary. Patients with Staph aureus infection are likely to have fulminant course, while patients with Streptococcus infection will have more protracted course. Patient will at the same time complain of fatigue, anorexia, weight loss, night sweat, joint pain, back pain. All these things are very common symptoms of long-standing infections or post-viral fever. So for our practical purpose, we usually classify the manifestations into cardiac and non-cardiac. The cardiac manifestations are at first those of his primary disease, like aortic valve disease or mitral regurgitation or cyanotic congenital heart disease. But for endocarditis, he will start having a new or changing regurgitant marker. He might have congestive heart failure in 40% of cases due to severe valvular dysfunction, myocarditis, or intercardiac fistula. There will be perivalvular abscess leading to pericarditis or heart block leading to bradycardia. There may be embolization of the vegetation into the coronary artery leading to myocardial infarction. And the non-cardiac manifestations, again, for our descriptive purpose and all practical purposes, we divide them into two parts: the vascular phenomenon and the immunologic phenomenon. Just like aortic regurgitation, they all have very catchy names. like vascular phenomenon, there are Janeway lesions, conjunctival Splinter hemorrhage of the nail beds, major arterial emboli, septic pulmonary infarct, mycotic aneurysm, and intracranial hemorrhage. And the immunological phenomena are glomerulonephritis, Osler's node, rot spot, and rheumatoid factor. So this is a Janeway lesion. These are non-tender, erythematous, or hemorrhagic, macular, or nodular lesions on palm or soles. They are seen in bacteria leading to formation of microabscesses. Petechiae are pinpoint round spots that appear on skin over the heels, shoulders, oral cavity, palpebral conjunctiva, the buccal and palatal mucosa. They result from bleeding. They usually flat in touch and do not lose color when pressed. Subungual hemorrhage. Splinter or subungual hemorrhage are dark red linear or occasionally flame-shaped streaks in the proximal nail bed. It occurs due to damaged tiny blood vessels. Small amount of blood from the damaged vessels become visible through the nail. The bleeding creates a splinter-like line in the direction of the nail growth. Then there is this symptomatic systemic emboli. As has been said before, the infected thrombus may embolize, and these events usually antedate or coincide with the diagnosis and are infrequent after 2 weeks of therapy. Risks of embolization are greater in large vegetations, mitral vegetations, or vegetations with staph aureus. Embolic stroke syndrome may happen in 15 to 35% of patients. They may embolize into extremities and may produce pain and ischemia. They may adhere to the mesenteric vessels, giving rise to abdominal pain, paralytic ileus, or positive occult blood test in stool. If the emboli from a tricuspid valve travels to the pulmonary circulation, it can give rise to pulmonary embolism, septic pulmonary embolism. Then there's this mycotic aneurysm, which is actually a misnomer. It is not due to mycosis, it is due to bacterial infection. The embolization of contaminated particles from vegetations of infected endocarditis can lodge into the vasa vastorum of large arteries and lead to infection of the vascular wall. The inflammation is associated with infectious process, resulting in weakening the vascular wall and aneurysmal dilatation. This is quite a life-threatening condition and can affect from all the vessels from brain to the peripheral vasculature, giving rise to chest pain, back pain, focal neurological symptoms, can cause a palpable thrill or pulsatile mass in the peripheral artery. This is a mycotic aneurysm in the cerebral circulation, giving rise to hemorrhagic stroke. Now come the immunological phenomena. These are due to deposition of immune complexes in end arteries. Glomerulonephritis is one of the most prominent. There's immune complex deposition in the glomerulus. There can be glomerulonephritis from other causes like antibiotic-induced acute interstitial nephritis, acute tubular necrosis secondary to toxin or volume depletion, or microangiopathy due to disseminated intravascular coagulation. The rot spot is another important immunological phenomenon. These are oval retinal hemorrhages with pale center. They are actually cytoid bodies, and these spots can come and go, sometimes appearing and disappearing in a matter of hours. The Osler's nodes are small, tender, and subcutaneous nodules in the pulp of the digits. It results from deposition of immune complexes, as we have said earlier. They are occasionally proximal and persist for hours to several days. The rheumatoid factor is produced in response to intense immune response stimulated by chronic intravascular infection. Now, the generalized symptoms that we face are like that of musculoskeletal symptoms. There can be arthralgia, there can be myalgia, there can be back pain. Occasionally, there are true arthritis, non-diagnostic but inflammatory synovial fluid. The renal manifestation we have already discussed are due to renal insufficiency as a result of immune complex deposition. It may be due to azotemia as a result of development of progress during initial therapy. Focal or segmental glomerulonephritis or diffuse glomerulonephritis can occur. The neurological symptoms can be of embolic stroke, intracranial hemorrhage due to ruptured mycotic aneurysm. There can be purulent meningitis, and there can be other things like severe headache, seizure, and encephalopathy. One thing has to be said about, a few words has to be said about infective arteritis or infective endarteritis. This is the incidence of infective arteritis. These are associated with PDA. Vegetation usually occur in the pulmonary artery, pulmonary end of the pulmonary artery of the duct. Embolic events are usually of the lung rather than systemic circulation. Symptoms may be attributed like community acquired pneumonia. Other complications may be hoarseness of voice due to left vocal cord paralysis, dissection or spontaneous rupture of dilated pulmonary artery, even aortic dissection. So now let's come to the diagnostic criteria. It's a very well-known Duke's criteria. They have two groups, the major criteria and the minor criteria. The major criteria has two headings. One is isolation of the pathological bacteria, pathological organism. Other is evidence of endocardial involvement. So to identify the bacteria we have in organism, we have to do blood culture. Actually, it is said that typical microorganism consistent with infective endocarditis from two separate blood cultures, or persistently positive blood culture, which is defined as at least two positive cultures of blood where samples were drawn 12 hours apart, or all three or majority of 4 separate cultures of blood when first and last sample was drawn 1 hour apart. But again, a single positive blood culture for Coxiella burnetii will do. And evidence of endocardial involvement through imaging. Echocardiogram positive for infective endocarditis, which is defined as finding of oscillating intracardiac mass on valve or supporting structure in the path of the regurgitant jets, or an implanted material in the absence of an alternative anatomic explanation, abscess or partial or new dehiscence of prosthetic valve. I'm sure Kabir-Zaman sir will be saying a lot about this. And there are the minor criteria, which are the predisposing factors, which Ismat has described. There has to be fever, the vascular phenomenon, as we have discussed already, or the immunological phenomenon, and microbiological evidence of positive blood culture, but does not meet a major criteria. That means I've got a single positive culture. And now to define as endocarditis, I have to have the pathological criteria. And if I consider the clinical criteria, there has to be 2 major criteria, 1 major criteria with 3 minor criteria, or 5 minor criteria. And it will be possible infective endocarditis if there is 1 major criteria and 1 minor criteria, or 3 minor criteria. And it is rejected, the diagnosis is rejected if there is firm alternative diagnosis explaining evidence of infective endocarditis or resolution of the syndrome with antibiotic therapy less than 4 days. And it does not reappear. When we are talking about all these criteria, we must not forget our old friends, the routine investigations. In the beginning, I said there are almost nothing which are 100% in this disease. But we must remember the erythrocyte sedimentation rate, C-reactive protein level, and circulating immune complex titer after 6 weeks into the disease is almost always present. Besides that, we must check for renal function, liver function, chest radiograph, and and ECG to find out if there is any complication. I would like to say a few words about blood culture. Everyone keeps asking these things. How to take the blood culture? The ACC and AH and ESC has recommended at least 3 sets of blood cultures from different venipuncture site and at least 1 hour between the first and last draw. Whereas the British Society of Antimicrobial Chemotherapy recommends 2 sets of blood cultures within 1 hour of each other in patients with suspected acute endocarditis, and 3 sets of blood cultures spaced 6 hours apart in case of suspected subacute or chronic endocarditis. I must mention one thing, that each culture, each draw has to be for 2 cultures, one aerobic and another anaerobic, and each media needs at least 10 ml of blood for a perfect culture. So to draw the blood, we must observe strict antiseptic techniques. We should avoid sampling from intravascular lines, which we frequently do. Adequate volume of blood for culture has to be taken, that is 10 ml for each bottle. Standard blood culture incubation time of 5 days are adequate for recovery of almost all cultivable cause of endocarditis, including the HASEC organism and Candida. We must remember human blood contains a number of substances like complement, lysozyme, phagocytic, WBC, which are capable of inhibiting microbial growth. So to optimize the diagnostic yield, blood should be diluted adequately in the culture broth to minimize the effect of these substances. And another thing is very important, that the blood has to be inoculated within 2 hours to have a good culture. Because by 4 hours, these things take up their action and destroy our sample. In one third of these cases, culture is obtained from patients already receiving antimicrobial agents. So there are specific products that are designed for cultures in patients with receiving antimicrobial agent. These are antimicrobial removal device, Bactec resin-containing media, or the one we all know, Bacti alert fan method. Negative blood cultures are due to contamination or antecedent antimicrobial therapy, or presence of organisms like Coxiella burnetii or Bartonella species, which may be culture negative. Fungal endocarditis are caused by Candida and rarely other like Histoplasma or Aspergillus. And these Histoplasma and Aspergillus are mainly in patients with malignancy or injecting drug abusers or presence of prosthetic heart valves. So for this, we might ask for separate investigations. Other lab techniques which are important besides culture are serological tests that can be used to implicate causally some organisms that are difficult to recover in blood culture like Brucella or Bartonella, as we have said already. Pathogens can also be identified in vegetations by culture and or direct fluorescence antibody technique. Use of polymerase chain reaction is also another option. I'm not going to say too many words about echocardiography, as we have our very expert faculty on that, but still a few words I would say, that is transthoracic echocardiography is non-invasive and exceptionally specific, but it cannot image vegetation less than 2 millimeter in diameter. It allows anatomic confirmation of infective endocarditis, sizing of vegetation, detection of intracardiac complication, and assessment of cardiac function. Transesophageal echo is safe and detects vegetations in 90% of patients. It is optimal method for diagnosis of prosthetic valve endocarditis. It's able to detect myocardial abscess, valve perforation, and intracardiac fistula. When endocarditis is likely, this can be repeated after 7 days. I think I will end here. Thank you very much.
Thank you, Dr. Tawfiq Shariha, for your elaborate discussion. You have got good number of questions. There is a good number of questions for you. So to start, why there is 12 hours apart sample? Why samples are taken, blood culture sample is taken 12 hours apart? Is there any specific reason?
It is said.
And why three sample?
Sir, in the criteria, it has been said to prove persistently positive. To prove this persistently positive, we are taking wide apart and from different sites, wide time apart. But this is only applicable for subacute bacterial endocarditis, not for acute endocarditis. In acute endocarditis, patients are really sick, and I cannot wait 12 hours to start my antibiotic treatment. So I'll take 2 sets of sample, 1 hour apart, and start my treatment.
Thank you. So you need to prove the persistent bacteremia. That is very important. So there was another question: why one positive culture is not enough?
Yes, Wadud sir.
Acha, please, yes.
Actually, in infective endocarditis, it has been seen there is not persistent bacteremia. There is a periodic, episodic bacteremia, and the best way of getting a good culture is actually taking a blood sample during the peak of the fever. That's the best way. And because of different time, there is a chance that if the patient has been on antibiotic, one will be away from the time of administration of antibiotic, the previous time. That will give a better result. And from different part, because if both the culture report same organism, you can be sure it's a true culture. And if it refers to organism, then it can be sure one of them is a contamination. These are the principles actually.
Okay, thank you very much. So there are another question. If one culture is positive and patient has symptoms, but there is no other criterion, can we start treating the patient as infective endocarditis?
Actually, if we consider possibility, so it comes as a, if I get one, it comes as a minor criteria. If other minor criteria are not present, but the patient has definite underlying disorder like surgically constructed shunt or cyanotic heart disease, and that bacteria is, for our country, I can say that we have actually used it, though it is not ideal, but we do follow this, that if there is one bacteria which is the causative, like streptococcus or staphylococcus we get in, and we can start antibiotic. And in our situation, when repeated culture is difficult, we actually do it, though it's not ideal.
Actually, for starting the treatment of infective endocarditis, clinical judgment is the first one. If a patient having clinical sign symptoms simulating with that of the infective endocarditis, you can take the blood culture immediately, but you should start the treatment as soon as possible. If it is acute, you have to start the empirical treatment, then followed by specific treatment after getting the result of the blood culture. That is why you cannot wait for the culture or taking blood culture or others. It should be giving emphasis on the clinical diagnosis and manifestation of the patient.
Thank you, Professor Fazlur Rahman, for your kind comments. So our next presenter, if there is no more questions, so we'll be moving to our next presenter. Our next presenter will be Associate Professor Dr. Muhammad Kabir Zaman. He will be talking about the echocardiographic features of infective endocarditis. He needs no introduction, so I skip the introduction part of his. So, Professor Kabir Zaman, please.
We have already learned about the diagnosis. Actually, infective endocarditis is a clinical diagnosis. And it in combination with clinical, bacteriological, and echocardiographic findings of valvular vegetation that allows an accurate diagnosis of endocarditis. So I would encompass or concentrate on echocardiographic findings of infective endocarditis. And you can see as you have learned about the due criteria, the major criteria, and among the major criteria, there is positive blood culture and evidence of endocardial involvement. Again, under the evidence of endocardial involvement, there is three components. Main component is the positive echocardiogram for infective endocarditis. So I will concentrate on positive echocardiogram of infective endocarditis according to due criteria. And what are the tips? These are the vegetations, abscess, pseudoaneurysm, intracardiac fistula, valvular perforation, aneurysm, new partial dehiscence of the prosthetic valve. And by echocardiography, we'll concentrate to find out these parameters of infective endocarditis. So a comprehensive echocardiographic imaging of suspected infective endocarditis should be guided by an index of clinical suspicion while maintaining an objective differential diagnosis of finding that would represent or mimic endocarditis. So what is the goal of the echocardiography? So goal of the echocardiography is to find out the vegetations, its presence, location, size, number of valvular involvement, and dysfunction of the affected valves, and underlying anatomy of the affected valve, and impact of valvular dysfunction of left and right ventricular systolic function. And obviously, you have to find out the complication of the endocarditis like paravalvular abscess, pericardial effusion, like so. So regarding the transthoracic and transesophageal echo, transthoracic echo is adequate in some cases, as it has been told by the Dr. Tovik Sharia, but transesophageal echo imaging is more sensitive and specific, and both for detection of the valvular visitations and for detection of complications. Now I will talk a few words regarding the visitation. What is this? Visitations are hallmark finding of infective endocarditis. And these are oscillating intracardiac mass. Oscillating intracardiac mass without an alternative anatomic explanation. How does it look like? This is the morphological description. Is an abnormal echogenic irregular mass, usually attached to a valve. Site of attachment of on the upstream side of the valve leaflets, and the vegetation attached to valve have independent chaotic motion. So these are the prevalence of valve involvement. Most common involvement is mitral valve, as previously been talked about. This is the diagrammatic picture showing, you can see the aortic valve. The vegetation, always, most of the time it is attached to the upstream side of the valve. In case of aortic valve, this is the upstream side for aortic regurgitation. So the vegetation is found on LV side of the aortic valve. And this is the mitral valve. For mitral regurgitation, this is the upstream side of the valve. So vegetation is attached on the left atrial side of the mitral valve. This is the still picture, transesophageal echocardiography. You can see two vegetation, one attached at the aortic valve, another attached at the posterior wall of the aorta. The size of the vegetations has already been talked about it, but fungal vegetations tends to be larger than those caused by bacterial infections, and vegetations involving the tricuspid valve tend to be larger compared with vegetations of aortic valve and mitral valve. And you can see that the large vegetation, fungal vegetation attached to mitral valve. Now, regarding the size of the vegetation, what are the size? As already Dr. Tawfiq Shah here have told it, but vegetations of 2 to 3 millimeter in dimension can be detected. So, what are the findings of the vegetation? These are the positive findings, and these are the negative findings. What are the positive features? These are low reflectance, attached to valve in upstream side, irregular shape, amorphous, mobile, oscillating, associated tissue changes, valvular regurgitation. Negative features are high echogenicity, non-valvular location, smooth surface of fibrillar, non-mobile. So this is the still picture of parasternal long axis view of transthoracic echo, the vegetation attached to aortic valve. And this is the vegetation attached to mitral valve on a left atrial side. So this is in a cine movie. You can see the dancing and oscillating and chaotic movement of the vegetation. This is the typical picture of the vegetation. And in these cases, there is the aortic valve is involved, but it has been extended up to the anterior mitral leaflet, and there is mycotic aneurysm of the anterior mitral leaflet. So this is another picture of the tricuspid valve vegetations attached on RSI side. So about the prosthetic valve vegetation, there is some peculiarity. What is that? Vegetations on prosthetic valve most often occur on the base of the swing ring of the structure, not at the leaflet. So this is the still picture of the transesophageal echo. The vegetation is attached to the swing ring. Now, pacer lead infections. Pacer lead vegetations resemble valvular vegetations, a mobile mass attached to pacer lead with independent motion. But note it that small fibrinous strands are common on pacer leads, and small thrombi also may be seen. And this is the picture of the vegetations, and this is the picture of thrombus, infected thrombus. Now about the non-bacterial thrombotic endocarditis, these are found in malignant disease and systemic lupus erythematosus. And these are the morphological description of the non-bacterial thrombotic endocarditis. These are the vegetations tends to be smaller, are located near the leaflet base, show variable ecodensity, have less independent motion. And this is the picture of non-bacterial thrombotic endocarditis. This is the mitral valve involvement. Now, what are the structures that can be mistaken for vegetations? These are the differential diagnosis of the vegetations. One is the papillary fibrillous tumor, myxomatous mitral valve disease, non-bacterial thrombotic endocarditis, thrombus, beam weight artifact, normal valve variants such as limbal excrescence or nodule of Arantius. This is the limbal excretions of the aortic valve. It is the old age process that it occurs in the old ages associated with hypertension. So this is another picture. It is the blood cyst involving the anterior mitral leaflet, not the thrombus, vegetation. And it is the white base, you can see, and it does not have oscillating movement. Now, what are the complications of the endocarditis? These are the structural complications, and these are the sequence of the hemodynamic complications. What are the structural complications? As the leaflet rupture, frayed leaflet, leaflet perforation, abscess, aneurysm, fistula, prosthetic valve dehiscence, embolization, pericardial effusion. And these are the hemodynamic consequences of regurgitation, valve obstruction, heart failure, intracardiac shunt, temporary perivalvular regurgitation. Now, what is meant by the perivalvular extension of the infection? This is very important. It is an extension of the infection towards the perivalvular tissue. And these are the fate of the perivalvular extension of the infection. What are these? Paravalvular abscess, mycotic aneurysm, aneurysm of the sinus of Valsalva, dehiscence of the prosthetic valve ring, and fistula. Regarding this mycotic aneurysm, some of the authors have mentioned it as a mycotic false aneurysm, but both the things are same. Now, I will talk few words regarding the paravalvular abscess. A high index of suspicion is needed by the echocardiographer, and subtle abnormalities suggesting a valve abscess should be carefully evaluated. And an abscess is a localized pocket of infection, most often caused by staphylococci and enterococci. So, what is the description? Morphological, this is the morphological description of the paravalvular abscess. I'll show the image. The cardiac abscess is either echoluscent or echodense mass that distorts the normal anatomic boundaries of the periannular region. Typically, abscesses occur in the valve annulus, adjacent to the infected leaflet tissue, and again, more common with aortic valve than the mitral valve endocarditis. And this is the aortic valve endocarditis, perivalvular extension of infection, most often targets the mitral aortic intervalvular fibrosa. Now, what is this mitral aortic intervalvular fibrosa? You can see this is the mitral aortic intervalvular fibrosa. It is the space in between the non-coronary cusp of the aortic valve and the anterior mitral leaflet. In other words, it is the aortomitral continuity part of the fibrous skeleton of the heart, and it averts the floor of the transverse sinus. So every chance of development of the pericardial effusion. And this is the normal 2D parasternal loinges to show the mitral aortic intervalvular fibrosa area. This area is important because its thickness is less than 3 and it is the less vascular. So it is vulnerable for infective endocarditis for formation of the abscess. And this is the parasternal loinges of the zoom view of transthoracic echo, and you can see this is the thickening of the mitral annular intervalvular fibrosa, and this is the echodense and echoluscent area. This is the posterior wall of the aorta, and it is been thickened. This is the short axis view. You can see the distorted, thickened, and irregular thickness and shape of the annulus, aortic valve annulus, with some part echogenic, some part are echoluscent. This is the characteristic picture of the abscess, perivalvular abscess. And this is the transesophageal echo. This is the LA. This is anterior mitral leaflet. This is the non-coronary cusp of the aortic valve. This is the mitral aortic intervalvular fossa area. This is thickened. This is the posterior of LA. It is thickened. You can see some are echodense, echoluscent, and thickening. And this is the attached vegetation. So this is the typical picture of the paravalvular abscess of the aortic valve. And this is the short axis looking for the vegetation. Now, abscess may rupture to allow communication with one of the cardiac chambers. Now, I will talk about the mycotic false aneurysm or mycotic aneurysm, the same thing. What is this? It is defined as an echoluscent outpoaching of the vessel wall, or in case of aortic root, the coronary sinuses. And after the periannular abscess, mycotic aneurysms are the next most commonly observed form of perivalvular extension of the infective endocarditis. And again, this MAIF, that is mitral aortic intervalvular fibrosa, is the location where false aneurysm most frequently occur. How it looks like, this is the example of the mycotic aneurysm at the aortic root. You can see this is the mycotic aneurysm. This is the transesophageal echo. This is the anterior mitral leaflet. This is the non-coronary cusp of the aortic valve, and this is the, and you can see the color. In systole it enters into the aneurysm, in diastole it comes out of the aneurysm. And complication of the mycotic aneurysms are, it may expand along the circumference of the aortic annulus and root, and it may cause the local compression of the left coronary artery circulation, and it may rupture, have a fistular rupture into the aortic root or left atrium. And you can see that on a picture, the mycotic aneurysm of the aortic root, it ruptures into the right ventricle. Now, aneurysm of the sinus of the valsalva, it has been evaluated by dilatation of the aortic root. Now, rupture of aortic annular abscesses. What are the roots of abscess? It results in different complications of depending on exact site of rupture. It may have fistulae from right coronary sinus into the right heart chambers. It may, from non-coronary sinus, it may rupture to all 4 cardiac chambers. And this is an example of the native valve, rupture of the non-coronary sinus, and have an left and the right and the shunt developed between the aortic root and the right atrium. Now, the perivalvular abscess of the mitral and tricuspid valve. It has been a bit different from aortic valve. What are these? Mycotic aneurysm formation is quite uncommon for mitral annular abscess. But periannular dehiscence would be the most common complication, and particularly for prosthetic valve. And it appears as an increased thickening and echogenicity in the posterior aspect of the mitral annulus. Again, you can observe that both for aortic valve and mitral valve, the posterior aspect is sent into the basal segment of the ventricular myocardium or into the pericardial space. And you can see this is the abscess of the anterior mitral leaflet, but it looks like a mycotic aneurysm. And you can see this the video loop that this is the dehiscence. And in the setup of bi-leaflet mechanical valve, valves are moving very normally, opening and closing, but there is oscillating chaotic movement of the vegetation, and there is dehiscence. And obviously it leads to severe mitral regurgitation. You can see also the thickening of the posterior aspect of the mitral annulus. Now, embolization of the vegetations, as it has been already talked by, I will attention on things. Sometimes vegetations abruptly disappear from the heart because of embolization. Thus, a patient with infective active endocarditis may have no visible vegetation if recent embolization has occurred. Now, according to 2D echo, what are the things we have to look for? We need the multiple acoustic windows are needed for detection of the valvular vegetation. Because the vegetation is a focal structure, it is seen only in certain tomographic bands. And image quality is enhanced by use of a higher frequency transducer and magnification of the area of interest. Note, small normal variants of valve anatomy should not be interpreted as abnormalities. And image quality is optimized by use of minimum depth setting, adjustment of gain, and processing parameters. And so by 2D echo, make careful assessment of the valvular anatomy, evaluate the size and dimensions of all 4 chambers, evaluate left ventricular, right ventricular, are both systolic and diastolic. And a small pericardial effusion is seen in patients with infective endocarditis, but not purulent pericarditis due to direct extension from the paravalvular abscess. And regarding the Doppler echo, the qualitative and quantitative evaluation of the valvular regurgitation is done with Doppler echo as like native valves and evaluate the PA pressure. And 3D echo often improve the visualization of vegetation on thoracic echo in some patients. differential resolution and slower frame rates. And this is the vegetation. You can see the case of ventricular septal defect. This is the ventricular septal defect, and you can see the multiple vegetations. And this is the vegetation of the valve conduit from RVOD to main pulmonary artery. This is the valve conduit, and this is the vegetation. You can see the oscillating and chaotic movement of the vegetation. And see, this is the prosthetic tissue valve at the mitral position. Have an infective endocarditis with multiple vegetations and with chaotic and oscillating movements. And you can see the thickening and increased echogenicity of the posterior mitral annulus. Now the echo conclusion. The vegetations are abnormal irregular mass with oscillating movement. Perivalvular extension of the infective endocarditis should be carefully evaluated. Paravalvular abscesses commonly affect the MAIF, that is mitral aortic intervalvular fibrosa. Dehiscence commonly occur in prosthetic mitral valve. And wisdom implies the timely and rightful application of knowledge, and knowledge may even be a pitfall or an encumbrance unless you learn to use it justly. And thank you all for patient sharing.
Thank you, Professor Koviraz-Zaman. Yes, we can hear you. Thank you, Professor Koviraz-Zaman, for your elaborate discussion on the topics. As I see, there is no question for echocardiography. I think people have understood what you have said. So I have one question from you. My question is, what is the protocol of choosing between transesophageal echocardiography and transthoracic echocardiography in a patient with infective endocarditis? What is the protocol of choosing between these two?
Actually, most of the authors say they advocated that you must first go with the transthoracic echo. But if the transthoracic echo does not fulfill your clinical suspicion, then you can go for the transesophageal echo. One thing. Another thing is that if you want to measure the effect of the treatment or progress of the treatment on a vegetation side, then the modalities of choice is the transesophageal echo. And you have to select the same view, same image, then make a measurement of the vegetation for follow-up study. And it should be done at least after 7 days of treatment.
Assalamu alaikum, boro bhai.
Ji, bolen boro bhai. Bodda bolen.
What is the importance of size of the vegetation for the echocardiographic diagnosis?
Actually, we have shown it, the lower threshold for detection of the vegetation is 2 mm. But there is no higher size threshold. Threshold is evaluated for chance of embolization. And number is evaluated for the severity of the infection. It is not that this size will be evaluated indicative of infective endocarditis and this size is not like that. Even in the absence of endocarditis vegetation, your diagnosis may have the infective endocarditis according to Jones criteria. Minor criteria, 5 criteria will fulfill the diagnosis of the infective endocarditis.
With respect to our coronary angiogram, if the vessel size is less than 2 millimeter, that cannot be diagnosed by angiogram. এটা যদি এখন কম বলা হয়, এই ধরনের কোনো কিছু সাইজের ব্যাপার আছে কি না, যে if the vegetation size is minimum smaller, at that case evaluation cannot be done but cannot be effective.
No, there is no such parameter. The lowest threshold for vegetation, there is no parameter.
Actually, it depends on the wavelength of the higher frequency, you can see higher resolution.
Any comment from the
you can determine actually.
I want to add that actually there is
sound please.
Less than 2 millimeters.
Assalamu alaikum.
Sound.
Twin madam কিছু বলবেন?
শোনা যায়?
হ্যাঁ শোনা যাচ্ছে।
Actually, less than 2 millimeter size of vegetation usually not seen by transthoracic echocardiography, but with high resolution of transesophageal echocardiography, we can see even a smaller vegetation. So
even there is provision of doing intracardiac echocardiography if there is high suspicion. intracardiac echocardiography.
Yes, yes.
If you suspect,
I have one question, sir.
Please. I have one question. Yes. I have gone through different books and internet to find out the smallest possible size that can be detected by echocardiography. It is they have mentioned by transesophageal echo, you can differentiate, you can identify the minimum 2 millimeter, not 2 millimeter. And by transthoracic echo, many of the authors say that it is the 5 millimeter that you can detect.
In this situation, if there is clinical suspicion of infective endocarditis, but by transthoracic echocardiography, you cannot find any vegetation. In that case, transesophageal echocardiography is more sensitive with respect
Yes.
Definitely.
Transesophageal echocardiography is about 90% sensitive, and
90% with respect to the 70%.
Professor Badrujaman, I have a question to Dr. Badrujaman.
Please.
In some cases of infective endocarditis, we often find the transthoracic echo is normal or inconclusive, and the patient is too sick to undergo transesophageal echocardiography. Patient is unwilling, or the operator is unwilling.
Yes.
In this situation, is there any role of cardiac MRI in evaluation of vegetation?
I don't know it. Probably.
Yes, cardiac MRI has got some role in diagnosis or diagnosing the vegetation. Even cardiac CT also is done.
Yes, CT also.
Yes, cardiac CT has
CT
role. If renal function is okay, cardiac CT has role.
Cardiac CT has role.
In case of prosthetic pulse is CT type.
It is. I have one question, Kavarjaman bhai. If the patient has got already rheumatic heart disease with valvular lesion, how will you differentiate whether this is vegetation or this is the fibrosis or nodule related to rheumatic heart disease?
Actually, nodule and fibrosis will never show the oscillating or chaotic movement like the vegetation. The classical movement of the vegetation is very hallmark for infective endocarditis. If that type of movement and oscillation and chaotic movement of the vegetation is, you have a doubt that it may not be vegetation. Another thing, most of the time, the vegetation should be correlated clinically. It has been written in books. If you see the structure like vegetation, the patient have no symptom of any inflammatory feature, then it is not vegetation. My experience, want to talk you, so that whenever I find any vegetation, I ask the patient, please look at me. The face is a very good indicator. It looks very sick. Then I ask, do you feel any fever? He gives it a positive answer. Then I write down the vegetation.
Thank you.
So this is the clinical correlation. You must have the clinical correlation.
The last question, শেষ question, Kavarjaman bhai.
Sir.
আর বন্ধ করেন আমরা আলোচনা করে শিখি একটু।
আচ্ছা, আমাদের নেক্সট আরেকটা স্পিকার আছে তো, তাকে সুযোগ দেব আর কি। ফজল ভাই, পরে আমরা আলোচনা করব। লাস্ট প্রশ্ন হচ্ছে যে how to
what about the role of echocardiography in the diagnosis of vegetation acute rheumatic fever?
Acute rheumatic heart disease, there are nodule. Yes, that may be it. Actually, it is the echocardiography is not the diagnostic test. I am talking about. Infective endocarditis is a clinical diagnosis, but in acute rheumatic fever, it again there's some criteria that will help you. But you may or may not get this type of visitation in the setup of infective endocarditis. Professor Tuhinhak will add something.
Sorry, I didn't get the question. What was the question?
Sir,
in acute fever, there is valvulitis and lead to formation of some vegetation. Yeah, how can we diagnose, but we can evaluate is cessation by echocardiography. This is my just.
Differentiate between
Acute fever valvulitis usually
these
the
two.
valve thickness increases.
Sir,
If acute rheumatic fever, the valve thickness increases, and the vegetations are the same as Dr. Kabirazaman mentioned, the same differentiating criteria, the oscillating structure. But a nodular structure, the beating apparatus, usually the change of rheumatic, not.
Madam, Robins's একটা ছবি আছে, 3 pictures. One is rheumatic nodules on the valve, another is non-bacterial, another is infective endocarditis.
Yes.
In rheumatic nodules is very small, multiple, attached firmly and close to the leaflets. It never oscillates like that in infective endocarditis, and it is usually multiple. It is multiple.
Okay, thank you very much. It was a lively discussion about echocardiography. So our next speaker is talking about.
Am I audible?
Usually gives a beaded appearance. The small bead.
Right. And okay.
Thank you very much. So our next speaker is Associate Professor Dr. Ashok Gupta. He will be talking about the most important part of the topic, management of infective endocarditis. Dr. Ashok Gupta, please.
Thank you, sir. So management of infective endocarditis includes general management, specific management, follow-up of the patient, subsequent prophylaxis against infective endocarditis, and prognosis of the infective endocarditis also included in the management. General management includes the rest for promoting the healing of the infective endocarditis vegetation. Nutritional support is very much important in some cases, especially when the patient is with chronic rheumatic heart disease or patient with congenital heart disease is debilitated and sometimes immunocompromised because of malignancy, chronic renal disease, or maybe due to diabetes. Specific management includes antimicrobial therapy and surgery. Follow-up of the management and subsequent prophylaxis against infective endocarditis I will discuss later. What are the factors that should be considered before, during, and after therapy? First one is causative organism, host factors, and cardiovascular factors. Among causative organism already been described, Staphylococcus aureus is very much virulent organism in compared to very dense group of Streptococcus, and this produce rapid damage of the valve. On the other hand, culture negative infective endocarditis, especially when it's caused by fungus or by acid bacilli, that produce a prolonged course of the disease and difficult to treat, and prognosis is very poor with high mortality. On the other hand, host factor also contribute to the disease morbidity and mortality with decreased immunity, renal impairment, malignancy, diabetes. Especially important is renal failure, because many of the drugs that we use are nephrotoxic, especially aminoglycoside and vancomycin also. Cardiovascular status, if the patient has got previously rheumatic heart disease or congenital heart disease, prosthetic heart valve or materials, prognosis and treatment both are, prognosis is poor and treatment is also difficult. What are the clues for causative organism? This is important, especially when you start empirical treatment, because sometimes empirical treatment start a new empiricis. And sometimes when clinical features and culture report does not coordinate, then this clue is sometimes helpful, like history, physical examination, and clinical correlation. Community acquired pneumonia usually caused by viridans Streptococcus, that usually in the rheumatic heart disease or congenital heart disease patient. In dental or oropharyngeal procedure or infection, positive organism is the Streptococci. On the other hand, Enterococci is the common organism when there is genitourinary procedure or infections. In patients with intravenous drug abuse, Staphylococcus aureus is the commonest organism. On the other hand, prosthetic valve endocarditis, again the Staphylococcus aureus followed by Streptococcus is the common organism. In case of hospital-acquired pneumonia, Staphylococcus aureus is again common organism. These are the key points regarding organism. I will go very rapidly through it because it is also important for antibiotic therapy. Streptococcus viridans and Streptococcus bovis, these are penicillin sensitive and mostly penicillin sensitive if the MIC is less than 0.12 microgram per ml, that is called highly sensitive. In between 0.12 to 2.5 microgram, it is intermediate sensitive, and if the MIC is more than 0.5, that will be resistant. And it is mostly community acquired subinfective endocarditis. On the other hand, Staphylococcus aureus is coagulase positive, so it is rapidly invasive and destructive, can affect any valve, may even the normal valve or prosthetic valve, previously diseased valve also. Skin and subcutaneous tissue infection is the commonest cause. This is the commonest cause of infective endocarditis in prosthetic valve, hospital-acquired or IV drug user. Penicillin is usually not effective and needs multiple drug combination for at least 6 weeks. Beta hemolytic Streptococcus, on the other hand, always sensitive to penicillin. This is the causative organism for tonsillitis, causative organism for acute rheumatic fever. That is called group A Streptococcus. So never penicillin resistance happens with this group. This is also more virulent than the Streptococci, other group of Streptococci. Hershey bacilli, that is also oropharyngeal and upper respiratory tract organism, produce acute bacterial infective endocarditis and slowly growing and sometimes large vegetation. On the other hand, enterococci usually affects the elderly people, more than 70, and usually from genitourinary tract infection. And it is sensitive to aminoglycoside. The problem is aminoglycoside to the elderly people is very much difficult to give. So double beta-lactam means ceftriaxone with amoxicillin is a choice. There are some peculiarities and speciality in antimicrobial therapy in infective endocarditis, because most of the cases we need combination of therapy in a higher dose and frequent dosing also, and prolonged duration, 4 to 6 weeks and sometimes even more than 6 weeks. Why combination therapy is needed in infective endocarditis? Because of its synergistic effect that reduce the side effect of the drugs by reducing the individual dose, and sometimes bacteriostatic molecules become bactericidal when combination is used. This is very simple example. One is cell wall synthesis that prevents the cell wall synthesis like beta-lactam, including penicillin, cephalosporin, aztreonam, and up to the meropenem. And vancomycin is also cell wall synthesis inhibitor, but that is not beta-lactam. And if we use this group, that usually acts on the cell wall synthesis, and that is bactericidal. And it is mostly effective in gram-positive bacteria, much more effectively than gram-negative. On the other hand, aminoglycoside that acts on the ribosome, but it cannot enter through the cell wall of the gram-positive bacteria, so it is not effective. But if we use the beta-lactam or vancomycin with penicillin, with the beta-lactam, when the cell wall is destroyed, aminoglycoside can enter the cell rapidly and more efficiently. So this is the synergistic effect. On the other hand, DNA synthesis is inhibited by ciprofloxacin, levofloxacin, or moxifloxacin, that is the quinolin derivatives. These groups of drugs are mostly effective on gram-negative bacteria. Why frequent dosing is important? This curve is very important. This is the minimum inhibitory concentration, yellow curve. And for bactericidal effect and good effect of the antibiotic, we always try to keep the concentration of the antibiotics in the plasma at least above this level. If we use frequently, that is 2 or 3 times in a day, the curve looks like this. Most of the time, the concentration of the antibiotics is above the MIC level. But if we use once a dose at the end of the day, that is the last 6 or 8 hours, there may be the concentration that is below the level of MIC. So that may be the ineffective. Longer duration, why it is used? Because of therapeutic aim of our therapy is eradication of the infection, sterilization of the vegetation. But there is a challenge. What are the challenges? One is infection is focal. Second is vegetation don't have vascularity by itself. Third is inoculative effect. That is the minimum inhibitory concentration that needed to bactericidal effect is very high. Though it is in laboratory, MIC is low, but at the vegetation side, there is the concentration of the bacteria that is very, very high. Sorry. So in vegetation, the concentration of bacteria is 10 to 100 billions per gram of vegetation. So at this high concentration of bacteria, MIC in the laboratory that is acid definitively should be higher. Another fact that is very important is slow growth rate of the bacteria and low metabolism at the within the vegetation. And biofilm, that is another condition that produce the treatment very much difficult, because this biofilm, most of the beta-lactam antibiotic cannot cross this biofilm, but the vancomycin is a drug, rifampicin is a drug that can enter through this biofilm. Other cause, these fibrin platelets inside the vegetation, that also make the difficult for penetration of the antibiotics into the vegetation, and as well as host factor is also important here. So there we need prolonged and parenteral therapy for eradication of the infection. What are the key points? These are the key points regarding use of the antibiotics. One is penicillin. This is a very old drug, but now sometimes it becomes shortage in our store. It is a preferred antibiotics when the age is more than 70, even in renal failure and renal nerve impairment. And napsilin, it is not available. Cefazolin is available. Septagen, this is very commonly used, especially it is sometimes useful when the allergy to penicillin is mild. But if there is hypersensitivity that is mediated by IgE immunological reaction, Septagen should also be avoided. Then vancomycin is a choice. But vancomycin should not be used as a first choice of drug. That is only indicated when the penicillin or Septagen is intolerable or hypersensitive. It is also nephrotoxic. So that should not be used with gentamicin. But in some cases, it is very essential to eradicate the infection, especially Staphylococcus infection in prosthetic valve endocarditis. Gentamicin sometimes may have to added with the vancomycin. And as already I have been described, the synergistic effect of the gentamicin with vancomycin. And this is the quinolin derivatives. It is very much effective against the gram-negative organism, especially enterococci and Hasek group. And rifampicin, this is a very broad spectrum antibiotic This is antitubercular and anti-leprotic drug. Primarily, this should be used for that purpose only. But sometimes prosthetic valve endocarditis with Staphylococcus, this drug is very useful, and in combination with vancomycin and gentamicin, because this is the drug that can penetrate very effectively the biofilm of any bacteria, and meropenem, that should always be in reserve. This is a broad spectrum, kidney friendly, and better to keep it in reserve in a special situation. Dose and duration. Most of the dose is 4 to 6 weeks, but in certain circumstances, it may need more than 6 weeks, especially when there is a prosthetic valve endocarditis with Staphylococcus. And gentamicin dose, usually that we use, gentamicin should be 2 weeks, but more than 2 weeks sometimes required in prosthetic valve endocarditis with same as Staphylococcus. So this is the regime. There are 4 regimes as per guideline. I will not go in details. Streptococcus with native valve endocarditis, streptococcal infection producing the prosthetic valve endocarditis, Staphylococcus native valve endocarditis, and prosthetic valve endocarditis. This Streptococcus viridans producing native valve endocarditis maybe 3 groups. One is highly sensitive to penicillin, mildly resistance, and fully resistance. In that case, penicillin is the choice, ceftriaxone is the second choice, gentamicin is optional, and vancomycin only in case of hypersensitive to penicillin group. In mild resistance case, this is ceftriaxone is useful along with gentamicin to get the synergistic effect. And in case of resistance case, definitively vancomycin is the choice, with or without gentamicin. Better to avoid gentamicin. In prosthetic valve endocarditis, if it is highly sensitive to penicillin, then it can be used, but not less than 6 weeks. And ceftriaxone is second option also for 6 weeks, but most of the case, penicillin needs 4 to 6 hourly infusion. So it is very much difficult to maintain the IV channel and to give the injection. So why ceftriaxone is a choice of drug here. And in prosthetic valve endocarditis, always gentamicin is a reasonable choice along with beta-lactam. And if there is any degree of resistance, then treatment should be continued for at least 6 weeks. And Staphylococcus aureus, this is a very dangerous, especially when it involves the prosthetic valve. It should be used at least for 6 weeks along with gentamicin, and sometimes in combination with rifampicin. What are the key points in this regimen? Staphylococcus prosthetic valve endocarditis needs more than 6 weeks duration of therapy, 3 drug combination. Streptococcus prosthetic valve endocarditis, 6 weeks therapy. And Streptococcus native valve endocarditis, 4 weeks therapy. For culture negative endocarditis, factor that should be considered before starting treatment with culture negative endocarditis is epidemiological factors, community or hospital acquired or not, clinical features, what are the underlying cardiac disorder, and host immunity. Fungus is one of the cause that is very much difficult to treat, and commonest fungus that produce infective endocarditis is hospital acquired candida. Amphotericin B is a drug of choice, but with very high side effect like fever, rigor, hypotension, arrhythmia, bronchospasm, and nephrotoxicity. And sometimes it may need fluconazole for long time oral suppression therapy. Response to treatment. Usually bacteremia disappears within 3 to 5 days. And as the bacteremia disappears, patient symptomatically improve, but signs still may remain. But If the symptom does not disappear or bacteria persist in the blood culture, the following things should be suspected. One is antibiotic is not appropriate in dose or regime, large vegetation, intracardiac abscess, either paravalvular, myocardial, septal, or suppurative pericarditis, and sometimes metastatic infection. It takes longer time to get a response. And definitively, this is sometimes important, IV cannula, because with injection, sometimes after injection, patient feels rigor and fever. So that is definitively the IV cannula infection is embolizing with each injection and producing febrile episode. What are the indication of surgery? Heart failure is the commonest indication of surgical intervention. Usually that may be caused by regurgitation, sometimes by stenosis, that may be due to paravalvular leakage or valve dehiscence. Second common cause is perivalvular extension of the infection, because this is very much difficult to treat by medication. It may cause perivalvular or intramyocardial abscess, mycotic aneurysm, fistula, or valve dehiscence. Prosthetic valve endocarditis needs more surgical intervention than the native valve endocarditis. And Staphylococcus aureus infection definitively more risky, and that needs more surgical intervention. And incidence of perivalvular extension is around 30 to 40% in prosthetic valve endocarditis. Already been described by my previous speaker, T is more sensitive than transthoracic, and cardiac CT is superior to the transesophageal echo. There are some clinical and echocardiographic features that may suggest potential need for surgical intervention. One is vegetation, another is valvular dysfunction, and third is perivalvular extension. Vegetation surgery may be needed because of risk of embolization, like persistent vegetation after systemic embolization, anterior mitral leaflet vegetation, particularly if size is more than 10 millimeter, and more than on or more than on embolization even after treatment is started, and increasing size of vegetation in spite of appropriate medication. Valvular dysfunction. Surgery may be required because of heart failure or heart failure that is resistant to medical therapy. That may be the acute aortic or mitral insufficiency. Sometimes valve perforation or rupture may produce acute heart failure and needed for surgery. Perivalvular extension in the form of that may produce valvular dehiscence, rupture, or fistula. Another condition is second or third degree of AV block that indicates that definitively infection, abscess, or has extended to the perivalvular area of the aortic valve, leading to either AV node or bundle of his destruction. So this is another indication of surgery, early surgery. Follow-up and monitoring. Follow-up and monitoring, once infective endocarditis is healed, the local site still remain vulnerable for further infection. Valvular damage may regress over time and sometimes it progresses. So follow-up clinically and by echocardiography is mandatory. Follow-up of mycotic aneurysm by CT or MRI angio sometimes valuable because many cases it may remain silent, especially in the cerebral circulation till it rupture, leading to sudden death. Relapse and recurrent of infective endocarditis is not uncommon. What is relapse? Relapse if infection and sign symptoms appears within 2 months after finishing the clinically effective therapy. Staphylococcus aureus, Enterococcus means gram-negative bacteria are the more common cause of relapse of infection. And enterococcal infection of the mitral valve has got great potential for relapse. And recurrence, especially it is important in IV drug user. Infective endocarditis prophylaxis. Single dose of amoxicillin, ampicillin, ceftriaxone, or azithromycin at least half an hour to 1 hour before procedure, so that peak serum concentration is achieved at the time of procedure is prophylaxis in most cases. High risk group for infective endocarditis prophylaxis. Those who have past history of infective endocarditis, post-surgery or post-procedure, especially with mechanical or bioprosthetic valve. Implantable device like pacemaker, ICD or CRT does not need any prophylaxis. Regarding ASD, VSD and PDA device, first 6 months that may need prophylaxis, because this is the time where most of the materials become endothelized, but sometimes it may takes longer time, especially if the device is larger. With chronic rheumatic, with congenital heart disease, especially cyanotic congenital heart disease, if it is unrepaired, if it is repaired with some residual defect, there is palliative shunt or conduits, and after completely repaired, prosthetic materials is inside. That takes sometimes 6 months. True endothelization is the indication for prophylaxis. Another is cardiac transplant with valvulopathy. There are 2 risk groups. One is cardiovascular risk group, another is procedure-related risk group. Cardiovascular risk group is high risk group, already I have described. Another risk group is low or intermediate group. Intermediate group includes the aortic stenosis or aortic regurgitation, especially that is with bicuspid aortic valve, because here the jet of the aortic regurgitation or aortic stenosis is usually eccentric, and that produce more damage to the endothelium. The same is true for mitral regurgitation, especially when it is associated with mitral valve prolapse. It produce eccentric jet, and chance of injury to the endothelium is more likely. With mitral stenosis, when it is isolated, that is very low risk for infective endocarditis. Coarctation of the aorta, PTA and HCM are the intermediate risk. Other thing is the procedure-related factors. If it is high risk procedure to the infected foci manipulation or injury to the tissue, there is chance of bacteremia and leading to infective endocarditis. Usually recurrent bacteremia is more important to produce infective endocarditis than single episode of bacteremia produced by procedure. Whatever the guideline says, there is on notation there. Clinician and patient preference, especially in intermediate group of patient. And if the prophylactic with penicillin is minimal risk, then it can be given. What are the prognosis? Depends on host factor, whether the infection is acute or subacute. What are the causative organism, like fungus, pseudomonas is the highest possibility of mortality. Then to the staphylococcus and viridans with relatively better prognosis. Underlying valve or shunt anomaly, delayed starting of the therapy, definitively as Fazlur Rahman sir was stating, delayed therapy sometimes make the things difficult. And metastatic lesion, especially in the brain or in the kidney, that sometimes dictate the prognosis. Patient with heart failure definitively is the poor prognostic factor and poor response to the therapy. What is the mortality? This is Pseudomonas aeruginosa or enterococci, that is the hospital acquired. Mortality is more than 50%. When it is related to staphylococcus, mortality is 25 to 50%. Enterococci better than this group of patient, and viridans relatively better prognosis, 5 to 15%. Right-sided infective endocarditis, as already Ajit sir was telling, prognosis is definitively better than the left side, and chance of complication, because lungs work as a filter here, and overall mortality is 20 to 25%. There is sometimes complexity may arise in the treatment or management of infective endocarditis. Suppose a patient with mechanical prosthetic valve on warfarin. Patient developed ischemic stroke. So what should be the next plan of therapy with the warfarin? In that case, depends actually ischemic stroke, maybe the small size infarct with medium or large size infarct. In case of small size infarct, we should wait for 3 to 5 days with CT scan screening whether that converted to the hemorrhage. If it is medium size infarct, that should be we should wait for 7 days to see whether there is hemorrhagic conversion or not. And if it is large size infarct, we have to wait for 12 to 14 days. So it is better to discontinue the warfarin for at least 2 weeks so that vegetation and cerebral infection both are organized and healed partially, and then start with heparin with overlapping of warfarin. Anyway, NOAC is not approved for mechanical valve and also not approved for biprosthesis with atrial fibrillation. And if anyway the patient is on dual antiplatelet therapy for PCI or CABG, that can be continued safely. So with this, I want to thank for patiently.
Thank you, Dr. Ashok Datta, for elaborate discussion on the treatment and management. You have got a few questions. First of all, there is one question: how to start the empirical antibiotic therapy before the culture report comes? What is the empirical therapy we should give?
Empirical therapy, that is definitively an important issue, as Fazlur Rahman sir was stating before. If it is subacute bacterial endocarditis, then we can wait for at least 3 days before culture sensitivity report comes. And when the culture sensitivity report is in hand, we can start therapy. But in case of acute infective endocarditis, we should start therapy after sending the blood for culture and sensitivity with on beta-lactam with gentamicin. If the patient is yes.
There's the actually we usually start with that. First, gentamicin and beta-lactam antibiotic, either penicillin or ceftriaxone. Another question is, what is the protocol for a culture? Sir, please.
If the patient is very critically ill, in that case, we can also consider to add flucloxacillin.
Yes,
flucloxacillin.
That is.
Better drug is oxacillin, that is not available in our country. So flucloxacillin should be added with the suspicion of Staph aureus infective endocarditis. Another question is, what is the protocol of treatment for culture negative, initial culture negative endocarditis?
Culture negative endocarditis already been described. Commonest cause of culture negative endocarditis is early treatment of antibiotics before coming to hospital or after coming to the hospital. Any kind of antibiotics that may suppress the growth of the bacteria. So culture may be negative. So as usual, empirically that we use, in that cases, certain condition we have to evaluate. What is the patient's condition, whether he is acutely sick or not, whether there is prosthetic valve or previous history of rheumatic fever or infective previous history of rheumatic fever or cyanotic congenital heart disease, and depending on this we have to give the therapy. If it is acutely sick patient, most likely organism is Staphylococcus aureus. We should start with beta-lactam, gentamicin, and if there is prosthetic valve endocarditis, rifampicin is a good choice. And here the rifampicin dose is different from the antitubercular. It should be higher dose, 300 milligram TDS dose, not the single dose. And duration of therapy for any prosthetic valve endocarditis should be 6 weeks or more than 6 weeks. So empirical treatment, usually that clinically you have to judge. Suppose a patient has got the urinary tract infection or lower abdominal surgery, that should be treated as possibly the infection comes from here is enterococci. So cipro or ciprofloxacin or other group of quinolone derivatives is also important here.
Okay.
Regarding culture negative,
Other cause
is a very important issue and very difficult issue. If we think of repeatedly get the culture negative, but still patient having clinical features consistent with infective endocarditis, at least we have to think at least 2 or 3 common things. One already said by Ashok Datta, the patient getting antibiotic not. Another thing we have to consider atypical organism, especially fungus, chlamydia, and others. And another thing we have to consider, if their patient is strongly suspected of infective endocarditis, but blood culture is negative, gradually deteriorating. In that case, there may be a formation of the abscess either in the bone marrow or spleen or liver. That it should be considered and that should be evaluated in the setting of culture negative infective endocarditis.
Thank you, Dr. Ramsar. Then another question is that if a patient is already getting some anticoagulant due to some other issue, either atrial fibrillation or a prosthetic valve, and he develops endocarditis with vegetation and abscess, what should be the protocol of stopping or continuing anticoagulant in this case?
So this is a very difficult issue. Regarding anticoagulation therapy, those who are already on anticoagulation is a controversial issue. That in that cases you have to judge with the risk of anticoagulation therapy and benefit of anticoagulation therapy. If the patient is on prosthetic aortic valve or chronic atrial fibrillation, the patient should be and patient don't have any ischemic stroke and vegetation is less than 10 millimeter. Echo findings is very important here. That sometimes can give a clue whether how much possibility of embolization of the vegetation. If it is a very friable vegetation and chaotically moving, as Kobrijon Bhai was telling, chaotically moving, that may moves away at any time. So that is a very high risk patient. In that case, whether the anticoagulation will increase the risk of embolization, that is controversial. But anyhow, if the anticoagulation is life-saving or very much important, like prosthetic valve endocarditis, mechanical prosthetic valve endocarditis, or chronic atrial fibrillation, that we should continue.
Okay, thank you.
Yes.
I think the main issue is that if patient develops a stroke, even if it is ischemic stroke, there is a controversy of continuing anticoagulant, because most people they suggest that to stop anticoagulation even because it may cause hemorrhage in the ischemia. Either reduce the dose or monitor very closely the INR of the patient. Anyway, thank you very much. There were a lot of questions, but we have very less. The time is always over. So I request Professor Fazlur Rahman sir, please unmute yourself and have some comments on this discussion.
মানে একটা জিনিস জানতে চাচ্ছি যে আপনাদের এই ডিসকাশনটা মানে ইন জেনারেল না ফর স্টুডেন্ট রিলেটেড?
সবার জন্য
রিলেটেড স্যার।
সবার জন্য
মূলত স্টুডেন্ট রিলেটেড কিন্তু ওপেন ফর অল। আমাদের টার্গেট অডিয়েন্স হচ্ছে স্টুডেন্ট।
না, টার্গেট অডিয়েন্স না, মানে স্টুডেন্ট অল, মানে স্টুডেন্ট ইনক্লুডিং স্টুডেন্ট এন্ড টার্গেট অডিয়েন্স অলসো, তাই না? এই তো
আমাদের জি স্যার।
আমি নিঃসন্দেহে বলবো যে এটা একটা মহান উদ্যোগ। আর এই কোভিড এরাতে আমরা ম্যাক্সিমামই অনেকটা বেকারের মতো, কাজকর্ম নাই বললেই চলে। সেই ক্ষেত্রে আমরা এই একাডেমিক ডিসকাশনের মাধ্যমে অন্তত নিজেদেরকে কিছু জ্ঞান অর্জনের পাশাপাশি নিজেদের যে এই যে আপনার কোভিড রিলেটেড যেটা ফ্রাস্ট্রেশন এবং ডিপ্রেশন, সেখান থেকে কিন্তু আমরা অনেকটা মুক্তি পাচ্ছি। এবং এই জন্য দেখবেন যে অনেক ওয়েবিনার বা একাডেমিক ডিসকাশন হচ্ছে। আমি এটাকে ব্যক্তিগতভাবে স্বাগত জানাই। আর আজকের যে ডিসকাশন ইনফেক্টিভ এন্ডোকার্ডিটিস ইজ এ ভেরি সেনসিটিভ ইস্যু এন্ড ভেরি ইম্পর্টেন্ট অ্যাসপেক্ট ইন দ্য কার্ডিওলজি from the point of treatment as well as diagnosis. All speaker of this session has discussed each and everything of the infective endocarditis for me, after a long time, I learned a lot on this discussion. So I thanks the organizers, especially Professor Fazilatunisa Malik and Bodiuজ্জামান Bhai, Kobiruজ্জামান, Ashok, and Adut Choudhury and other panelists and students who take active part in this discussion. Thank you very much.
Thank you, Professor Fazlur Rahman, sir. Professor Fazila Malik, Madam, please come on live and say something about that. আপনাকে দেখা যাচ্ছে না
বদিউজ্জামান ভাই, এর মাঝখানে ছোট্ট একটা আপার আগে আপাতত কনক্লুড করবেন, আমি একটা জিনিসের সবার দৃষ্টি আকর্ষণ করি।
জি বলেন, প্লিজ প্লিজ প্লিজ।
আমরা কিন্তু এখন এই দেশে একটা জিনিস প্রায় পাচ্ছি ইনফেক্টিভ এন্ডোকার্ডাইটিস, সেটা হলো আয়াট্রোজেনিক, বোথ পিটিএমসি রিলেটেড এবং পিসিআই রিলেটেড। এটার কথা আমাদের বোধহয় একটু অ্যাওয়ারনেসে সবার ঢোকানো উচিত। দিজ আর পিটিএমসি রিলেটেড যেটা, সেটা কিছু মানে প্রায় 80% মর্টালিটি আমার ঢাকা মেডিকেলে যে যতগুলো পেশেন্টের ভর্তি হয়, সারা দেশ থেকে বিভিন্ন জায়গা থেকে পোস্ট পিটিএমসি ইনফেক্টিভ এন্ডোকার্ডাইটিস এসে ভর্তি হচ্ছে, অ্যারাউন্ড 70% 80% মর্টালিটি। আর পোস্ট পিসিআই যেগুলো ইনফেক্টিভ এন্ডোকার্ডাইটিস পাইছি, একটা পেশেন্টকে আমরা বাঁচাতে পারি না। উই হ্যাভ সিন এট লিস্ট 6 পেশেন্ট ওভার দ্য লাস্ট 3 years।
পোস্ট পিসিআই স্যার,
পোস্ট পিসিআই, পোস্ট পিসিআই
না ঠিকই আছে, কারণ কার্ডিয়াক ইন্টারভেনশন রিলেটেড এন্ডোকার্ডাইটিস
probably 5 or 6 patient and none of them has survived.
পোস্ট পিসিআই টা স্যার আসলে ইনফেক্টিভ কোথায় হয়েছিল? অ্যাওরটিক ভালভে স্যার?
না না, আমাদের
আর্টারি অ্যানিউরিজম গুলো স্যার,
করোনারি আর্টারি,
আর্টারি অ্যানিউরিজম হয়তো মাইক্রোটিক অ্যানিউরিজম, এবং
এটা কিন্তু বাইরে বলা হচ্ছে এটা ইনভেরিবলি ফাটাল হয়ে যাচ্ছে। কাজে এটা আমাদের ভিজিলেন্ট রিগার্ডিং ডিউরিং প্রসিডিউর, এটাই আমি সবার দৃষ্টি আকর্ষণ করছি।
এটা কিন্তু একটা ইম্পর্টেন্ট দিক ডক্টর অদূত উল্লেখ করছে। ইদানিং কিন্তু দেখা যাচ্ছে যে আমাদের যে সমস্ত ইস্যু মানে পেশেন্ট আফটার দ্য প্রসিডিউর দে ডেভেলপ ফিভার রেসপন্ডিং উইদাউট মানে নট রেসপন্ডিং টু দ্য অ্যান্টিবায়োটিক্স। ইন দ্যাট কেস we can suspect this situation, that is infective endocarditis. It is very important aspect of the discussion.
Yeah, thank you. Professor Fazila, Fazila আপা কিছু বলেন?
আর কারো কিছু বলার আছে? না, খালেদ হোসেন ছিল, প্রশান্ত আছে, প্রশান্ত কিছু বলতে চায়?
প্রশান্ত আড়ালে আছে, পর্দার আড়ালে আছে।
First of all, let me my heartfelt thanks and gratitude to Professor Wadud and Professor Fazlur Rahman, because you came here and made this discussion lively. So thank you so much, because the students really learn from the questions and the different insights that you give. So we are really, really grateful for this, and please keep it up. And I would request Professor Fazlur Rahman as well as Professor Wadud to visit us as often as possible. We have this every week, and to request your students to also come. Many of the students do join, but I think when all the students take part, and in fact, I don't know whether Professor Fazlur Rahman is aware of it. Last 2 weeks ago, we had an evaluation test, an MCQ, and the student who stood first, he is a student of your MD third part from Bangabandhu Sheikh Mujib. So your students are studying very hard, and I think one of the students was from Dhaka Medical as well. So both of you are doing a great job, and they took part in the MCQ, which was very positive. I'm grateful that you all came, and all the speakers were, as usual, very, I'm biased, so I shouldn't be saying this. This is for Professor Wadud or Professor Fazlur Rahman to say, but our speakers were very good, and thank you for giving me the opportunity of saying a few words. And I would request Pauline to please upload this lecture so that the students can again go through it, so it will help them really recapitulate and sort of work on the finer points from an examination perspective. Thank you, everyone. Thank you so much. Professor Bodiuজ্জামান, your concluding words, please.
Thank you very much to all the panelists and speakers and the students and all the audience. And with that, we want to finish this discussion today, because it's already too late. It's 5:15. So thank you very much. See you soon. See you again next week.
Next week
at the same time.
Next week is going to be different. Now we are doing alternate weeks. So 1 week we're going to do intervention. So next week I would request all of you to please request your technicians to get enrolled, because that is a session which will be very helpful for junior cardiologists and for technicians. So it's like taking angiographic views, then how to manage complications in the cath lab, what is a nurse's perspective of managing a cath lab. So nurses and technicians' perspective, but it will be really very helpful from a young physician's point of view. So that's next week. So I would request all of you.
ওইটার প্রচারটা এখনই করে দিলে ভালো হয়, মানে ইয়েটা দিয়ে দেন তাহলে সবাই খুব বাইরে খুব ভালো উদ্যোগ, খুব ভালো কাজ।
Thank you. Thank you.
Thank you. Thank you very much.
হবে ASD. So we are doing congenital and intervention every alternate week from now on. Yes. Thank you so much.
Thank you very much.
Thank you.
Thank you.